We left off last time, we had talked about hemoglobin, the fact that there's 4 heme groups in a hemoglobin molecule, 2 alpha chains, 2 beta chains, and that fetal hemoglobin consists of 2 gamma chains in place of the 2 beta chains, and that alters the affinity of oxygen for hemoglobin. And we'll talk more about that in a minute, but basically it increases affinity such that because we have a high hypoxic environment in the fetus, because they have an arterial PO2 of only 25 millimeters of mercury, we need to facilitate the binding of oxygen to hemoglobin in the placenta, and we're okay with releasing it a little more slowly because the hypoxia associated with the fetus is so low anyway that it helps to facilitate, and we still get oxygen to dissociate. So we're going to go ahead and talk about the reaction and transport of carbon dioxide. Remember, carbon dioxide is produced in the tissues at the tissue level. So as we produce CO2 in the tissues, it will diffuse into the plasma. As it diffuses into the plasma, it's important to know that only 7% of the CO2 will be dissolved in plasma, which is still higher than oxygen. Oxygen was only at 2%. So CO2 definitely has a higher diffusion or solubility in fluid. So you can see that here we get 7% associated. And just like oxygen, the rest of the CO2 diffuses into the red blood cell. Within the red blood cell, part of the CO2 will bind directly to hemoglobin, which is about 23% of the CO2 that's produced. It binds to hemoglobin at differential sites than oxygen does. So it's important to remember they are different sites, but yet still CO2 will bind to hemoglobin, forming a carboxyhemoglobin. As well as what happens in the red blood cell, CO2 will, in combination with water and the presence of an enzyme called carbonic anhydrase, will form carbonic acid. This carbonic acid immediately dissociates to bicarbonate, a bicarbonate ion, and a hydrogen ion. This hydrogen ion primarily will bind back to the hemoglobin. And this also is another different site on the hemoglobin that binds this hydrogen ion. Now this bicarbonate ion will actually move from the red blood cell back to the plasma by what's called a chloride shift. That means that a chloride ion moves into the red blood cell as the bicarbonate ion moves out of the red blood cell. So now that this bicarbonate will sit in the plasma, and that's how it's transported back to the lungs. So 70% of all the CO2 produced at the tissue level is transported back to the lung as bicarbonate in plasma. Now, as we get back to the lung, we have the exact reverse reaction occur, just like in oxygen transport, the reverse occurs. So once again, as we get to the tissue level or back to the lung, we have a diffusion of this CO2 that's dissolved. That will move across into the lung or the alveolar space. As the concentration of CO2 diminishes in the plasma, we have dissociation of the CO2 from hemoglobin. This will dissociate, diffuse into the plasma, and then diffuse into the lung. As well, when we get back to the lung, because of the low concentration of CO2 in the plasma, we have the bicarbonate moving back into the red blood cell, once again by the chloride shift. So now we have a chloride ion moving out of the red blood cell as the bicarbonate moves back in. This will bind to that hydrogen ion that was bound to the hemoglobin, once again, and form carbonic acid. And carbonic anhydrase, once again, will convert this. This is a purely reversible equation, back to water and CO2. And then again, this CO2 diffuses out of the red blood cell into the plasma and then into the alveolar space. So it's a complete reversal of the same reaction that we have at the tissue level when CO2 is produced and moves into the plasma and into the red blood cells. Make sure you understand this equation, what occurs, the direction it occurs, and most importantly, make sure you remember that bicarbonate, it consumes or uses about 70% of the CO2, and that's how it's transported back to the lung. So the majority of the CO2 is transported as bicarbonate. Now, bicarbonate ion is actually a nice buffer. It helps maintain any acidosis that may occur due to excessive exercise, anaerobic exercise, where you have buildup of lactic acid. So this actually helps to buffer that solution as well. So bicarbonate's a very important molecule here, or ion. Not only is it the transport of CO2, but it also helps to buffer the acidity when we have high CO2 production. Now we're going to talk more specifically again now about hemoglobin and its binding of oxygen. Now when we talk about the binding of oxygen, we're talking about at the arterial circulation, at the alveolar site. Remember, we have 100% or close to 100% of the hemoglobin is bound by oxygen. That means all 4 sites on the hemoglobin molecule have an oxygen molecule associated with that. So 100% saturation, as we talked about, refers to 20 volume percent as a concentration, because the oxygen-bound hemoglobin is 98% of all oxygen that's being transported. So when we talk about content, the content refers to primarily the oxygen bound to hemoglobin plus the 2% that's dissolved in the plasma. So we have 20 volume percent at 100% saturation. Now, this here is called a dissociation curve. Dissociation curve refers to the release of oxygen from hemoglobin. So as we start at 100 millimeters of mercury of oxygen at the alveolar site, and we move toward the tissue. Now, as we get to the tissue level, we mentioned that at the tissue level, the partial pressure drops to about 40 millimeters of mercury. At this point, you can see that we go from 20 volume percent to 15 volume percent. What is that equivalent to in percent saturation? 75% saturation. Okay? So now we have 3 oxygen molecules still bound to the hemoglobin. One of those oxygen molecules is released from the hemoglobin and is utilized by the cells or the tissues in the peripheral. So you can see as we drop from 100 to 40, that's a 60 millimeter decrease in PO2 to allow 1 oxygen to be released. So now you can see here, now this is normal respiration. So anything below this is a reserve, because now this is the venous blood. It cycles back to the lung for reoxygenation. But all we did was we took 1 oxygen off the hemoglobin, and now we're going to replace that 1 oxygen as it gets back to the lungs. Now this is under normal resting conditions. So as we exercise and now we consume more oxygen, we're going to consume additional oxygen. Now we're going to release more oxygen. So as we exercise, we actually drop the PO2 down in the cellular compartment a little bit, because now we're consuming more oxygen due to exercise, increased metabolism. So now if we drop down to 10 volume percent, that means that now we're 50% saturated, and we only have 2 oxygen molecules left bound to the hemoglobin, and the second molecule comes off. But as you can see, when we get to this point, it only takes a drop of about 10 millimeters of mercury to get the release of the second oxygen molecule. That's called cooperativity. In other words, the oxygens are released more readily as we sequentially go down and release the additional oxygens. Okay, so you can see now they start to come off more quickly as we go to 1 molecule and absolutely down to 0 molecules. which typically doesn't happen very often because this would be an excessive amount of metabolism to have to consume all of the oxygen that's bound to the hemoglobin. So this reserve capacity is for increased metabolism. Make sure you understand the relationship between volume percent saturation, and the number of oxygen molecules bound to the hemoglobin. So this just reiterates what we just talked about. So once again, the content of oxygen is 20 volume percent at the alveolar site as we come to equilibrium. Normally, the venous oxygen content is 15 volume percent. So the difference between these two, we subtract the content of oxygen at the arterial minus the content of oxygen at the venous site. And this is going to be important when we calculate oxygen consumption. So that is our difference. So this tells us how much oxygen we consumed. And basically, the rest of this is our reserve. Now remember, the whole time, this line down here represents the oxygen that's dissolved in the plasma. So we start at 2% here, which accounts for a small amount of the total content. And even that will decrease as we get to the cell level. And as we consume oxygen, that decreases. Because remember, it's the decrease in the plasma that allows the movement of oxygen from the red blood cell into the plasma and then to the tissues. So we still see a decrease in this, but this is minimal compared to the content of oxygen associated with hemoglobin. So as you can see, the first oxygen comes off after a drop of 60 millimeters of mercury, the second at 10, the third will even be at 10 or less, as well the fourth would be even less than that. So you can see that we lose the last three oxygens from 40 down to about 5 millimeters of mercury. So within this range, the last three oxygens would come off. So this here is our normal oxygen dissociation curve when we're talking about oxygen and hemoglobin. Now we're going to talk about different things that can affect that. One is carbon monoxide. We mentioned that carbon monoxide has a very high affinity for hemoglobin. It binds hemoglobin very strongly. Now remember, carbon monoxide also has a very slow solubility or diffusion into the blood. So it may go in very slowly, but when it does, it binds hemoglobin 200 times stronger than oxygen. So as what we see here is that if we have carbon monoxide bound to hemoglobin and we get 100% saturation with carbon monoxide, our PO2 will drop all the way to 0 practically before this carbon monoxide will be released from the hemoglobin. Hence, carbon monoxide poisoning is very dangerous because when carbon monoxide does bind, it does not come off. It's almost irreversible. And I say almost because if we do have carbon monoxide poisoning, that can be treated in a hyperbaric chamber. Hyperbaric chamber increases the partial pressure very high, and it's what that does is it allows, not only do you go in a hyperbaric chamber, but you also breathe 100% oxygen. So when you breathe 100% oxygen at hyperbaric pressure, we increase the partial pressure of oxygen so high that it does eventually compete with the carbon monoxide. As that carbon monoxide comes off, that's removed from the body and oxygen replaces it. Now, under this circumstance, if we had 100% saturation with carbon monoxide, you would have no oxygen transport, no oxygenation. This is not compatible with life. So as what typically happens is we have a lower percentage of carbon monoxide binding, which just occupies a large amount of the hemoglobin sites. So it could be 50% saturated with carbon monoxide, and at least at that point you still have two oxygen molecules that you can utilize in the meantime. So obviously if you exercise while you have carbon monoxide poisoning, that would not be a good thing because then you would be very deficient in oxygen. And we're also going to talk about how carbon monoxide alters this dissociation curve of oxygen from hemoglobin. Another example of hyperbaric chamber treatment is when we treat what's called the bends. The bends is a nitrogen accumulation. You hear about divers sometimes getting the bends. The bends occur when you go to a great depth diving and you're breathing a regular air mixture. Regular air mixture has 78% nitrogen. Typically, nitrogen does not diffuse into our body. But as you dive at depth, you increase the barometric pressure to such a point that now you drive nitrogen into your tissues. And as you drive nitrogen into your tissues at high atmospheric pressure, now as you surface, the barometric pressure decreases. Those nitrogen molecules are slow to diffuse. So if you surface quickly, instead of the nitrogen being able to diffuse out of your tissues, back into your lung, and be exhaled, they now expand within your tissues, and that causes severe pain. So typically when somebody has the bends, that's nitrogen gas in your tissues expanding as you come to the surface. So to treat that, they go into a hyperbaric chamber, increase atmospheric pressure, which now shrinks the gas bubbles, so at least takes away the pain, and then they'll have you breathe 100% oxygen, and slowly, once again, that nitrogen will diffuse out, and because you're not breathing in any nitrogen, it facilitates the removal of nitrogen, and they bring you back to normal barometric pressure very slowly. So they give the nitrogen time to diffuse out of your tissues and exhale. So that's how they treat the bends. So that's very similar to carbon monoxide poisoning as far as treatment goes. And also they treat a variety of anaerobic infections with hyperbaric chambers, such as gangrene. That is a way that they can kill that type of bacteria. It's an anaerobe. So what they do is they increase the amount of oxygen to such a high content that these anaerobes can't survive. Gangrene is something that's very difficult to treat otherwise with antibiotics, etc. So hyperbaric chambers help to treat this type of infection because it is an anaerobe that causes this infection. So now as we look at this combination of curves, this is our normal oxygen dissociation curve. Once again, this is the arterial circulation. So when we look at oxygen content, we have an oxygen content close to 200 ml per liter of oxygen. So this would be equivalent to 20 volume percent. And as you can see, the oxygen dissociates as we drop our partial pressure of oxygen on the x-axis. Now we mentioned with carbon monoxide poisoning, so in this example we have a 50% carbon monoxide binding to hemoglobin. That means we have 50% oxygen. So if we look at this oxygen dissociation curve, we're at 50% saturation, which is about 10 volume percent, or about 100 ml of oxygen per liter. And you can see the dissociation is actually slower than the normal curve. So because carbon monoxide is bound very tightly, it actually alters the release of oxygen under normal conditions and slows the release of oxygen even more so. So we start with less oxygen and it slows the release of oxygen. So once again, carbon monoxide poisoning not only limits the amount of oxygen carrying capacity, but also slows the release of oxygen from the hemoglobin. So you can see you can get quite hypoxic before you get one oxygen molecule coming off. Remember, typically we're closer to 40 at the tissue level. Now you have to get all the way down to almost 10 before this oxygen will come off. So you're quite hypoxic. So carbon monoxide poisoning is very dangerous. And you can see if you get 50% saturation, that in itself could be very deadly. Now we compare this with an oxygen dissociation curve of a 50% drop in hemoglobin. Remember, if we drop the hemoglobin, we change the content. So if we only have 50% of the hemoglobin, our total content drops to 50%. because now that's primarily all the content is oxygen that binds the hemoglobin. So if we drop that, we start with 50% hemoglobin, and now we look at the dissociation curve. Now in this case, we start at 100% saturation, but we only have 50% of the hemoglobin. So on a curve of content, we're only at 50%. If this said saturation, this curve would look just like the normal curve. It would still be 100%. Okay, so don't get confused when we talk about anemia or loss of hemoglobin, loss of red blood cells. So the content decreases, but the saturation is still 100%. So we still have 4 oxygen molecules bound to each hemoglobin. However, because of the anemia, we see that it alters the release of oxygen. So you can see that under normal conditions, that first oxygen comes off at 40. Now if we have anemia, that also delays the release of oxygen. So that first oxygen comes off here closer to 30 millimeters of mercury. Okay? So it's important to realize that anemia also has an effect on release of oxygen or the binding of oxygen to hemoglobin. But don't forget, this is 100% saturation. As opposed to 50% carbon monoxide, that's only 50% saturation. So now we're going to look at measuring oxygen consumption. We already talked about oxygen consumption is proportional to the content of oxygen in the arterial circulation minus the oxygen concentration in the venous circulation. And we multiply that times cardiac output. And that gives us our total oxygen consumption per unit of time. So here you can see, once again, under normal conditions, we have a cardiac output of about 5 liters per minute. And this is our normal content, 20 ml of oxygen per 100 ml of blood in the arterial circulation, minus the 15 ml of oxygen per 100 ml of blood in the venous circulation. Hence, we do the calculation, comes out to 250 ml of oxygen per minute. Okay, so make sure you know that if we start at a different point, such as carbon monoxide poisoning, etc., how that's going to affect our oxygen consumption. Now, one thing we want to compare this with is under exercise. As we exercise, we increase our cardiac output, and we can easily increase our cardiac output 5-fold, up to 25 liters per minute. Also, our venous oxygen content, because now we're consuming more oxygen, we can actually increase that 3-fold. In other words, now we can consume 3 oxygens per hemoglobin instead of 1. So we decrease the oxygen content 3-fold, and therefore our oxygen consumption is then 15-fold normal. So you see how that works as we decrease this. So we're decreasing this number, and then we increase the cardiac output number. Oxygen consumption is now 15-fold normal. So oxygen consumption at exercise now becomes closer to 4 liters of oxygen per minute. So that's a pretty high consumption, but we have the capacity to do that. So because we have 4 oxygen molecules bound, under normal conditions we only consume 1. We do have room to move. Now, another point we want to talk about is that your spleen is known to actually produce and store red blood cells. So if you have anemia, your spleen will release and produce red blood cells to replace the ones that are lost. However, that occurs very slowly. It takes days, weeks to replace the red blood cells that are lost. So that's a long-term effect in humans. However, there are certain other mammals, such as seals, that have the ability to release these red blood cells from the spleen immediately. So that kind of explains why a seal can hold their breath underwater so long, causes what they do is they release these red blood cells, increases the hemoglobin content of their blood. Therefore, they can oxygenate that. They can increase their content dramatically. So now when they hold their breath, dive underwater, they have a lot more oxygen to consume. As the heart keeps pumping the blood around, there's still a lot of oxygen there available for them to use at the tissue level. So seals are able to hold their breath a very long time, unlike humans, because of this ability to regulate the amount of red blood cells in their bloodstream. Okay, so that's just a little tidbit to help demonstrate that this amount of hemoglobin in the blood is very beneficial for total oxygen content as we consume that oxygen. So once again, this represents exercise. We drop our partial pressure due to oxygen consumption. This is a threefold increase from 1 to 3. So we go from 5 volume percent to 15 volume percent. Okay? Or 5. So we go from 15 to 5. That's a threefold change. So you can see that under exercise, this is what happens. Now remember also, this is our oxygen diffused in plasma. That will continue to decrease as it goes down further as well, even though that's only a small percentage of the total oxygen content. As we mentioned before, oxygen binds to the hemoglobin. There's a separate site for the CO2 to bind to hemoglobin, as well a separate individual site for the hydrogen ion. So when we're talking about transport of CO2, we know that we get the CO2 to bind as well as the hydrogen ion. Now, these binding can also affect the oxygen dissociation curve. So the more CO2 that binds, we get a little different conformational change. It alters the affinity of oxygen as well with hydrogen. So if we look at increase in PCO2 or an increase in hydrogen ion or even an increase in temperature, all of which occur during exercise, all of this results in a decreased hemoglobin saturation. As what that means is it alters the release or it increases the release of oxygen from hemoglobin. So it decreases the amount of oxygen bound to hemoglobin. So as we have more CO2 bind or more hydrogen ion bind, the oxygen is released more readily. Okay, so that's going to come into play, and we can see what happens. So when this occurs, we shift this curve to the right. This is called a rightward shift. When we shift the curve to the right, it's important to see now at the cellular level, 40 millimeters of mercury, if we remember under normal conditions, that's where one oxygen is released. Now, if we release one oxygen, that occurs, we follow this across, it occurs here. So it occurs earlier. It occurs more like 45 to 50 millimeters of mercury. So as we increase the CO2 or the hydrogen ion or even temperature, we shift the curve to the right, and it makes oxygen release more readily and earlier than normal. And that's good because as we exercise, we increase our metabolic demand, we increase our oxygen consumption. So making oxygen more available is a good thing. So physiologically, that's what occurs, and that's how we accommodate increase in metabolism or increase in oxygen consumption. We shift the curve to the right. All right, so make sure you understand this rightward shift and that these are some of the effectors that cause a rightward shift. As well, this curve can shift to the left. And that can happen with a decrease in CO2, decrease hydrogen ion, or a decrease in temperature. That can shift the curve to the left. All right, so not only can it shift to the right, but it can also shift to the left in the opposite direction. And that's what we see here. So all of these items can shift the curve to the right or shift the curve to the left. And also there's another component here that we're going to talk about is 2,3-diphosphoglycerate. This is a compound that's produced in the red blood cells primarily in response to hypoxia. So if you go to altitude for a long period of time, say a matter of several weeks or months, you will increase the production of 2,3-diphosphoglycerate. And in doing so, that will shift the curve to the right as we increase that production. So obviously increasing it to the right facilitates the release of oxygen from hemoglobin, and that's a good thing also because it's induced by a hypoxic environment. In other words, our inspired oxygen is at a lower oxygen content. So therefore, releasing it more readily is beneficial. So likewise, that can go to the left. Now, one way that physicians calculate or compare this rightward shift to a leftward shift is by looking at the P50. The P50 is defined as the partial pressure of oxygen, that's the x-axis, at which 50% of the hemoglobin is occupied. Okay, so that's this point. So is what you do, if you want to know the P50 on a curve, is you come down to 50% saturated, come across until you hit the line, and then you come straight down, and this partial pressure is the P50. Okay, so in this case, the P50 is about 28 of the normal curve. Now, if we shift the curve to the left, the P50 decreases. And if we shift the curve to the right, the P50 increases. So physically, and the physicians will look at the P50, and that helps determine is it a rightward shift or a leftward shift. Okay, and remember, a rightward shift means we decrease the affinity of oxygen for hemoglobin. It comes off more readily at the tissue level, as opposed to a leftward shift, where now it binds tighter and it's more difficult to come off. So you can see that the oxygen does not come off as readily. However, when you look at most of these curves, it doesn't affect the saturation or the initial saturation very much. This effect is very minor because we go to 100% saturation. Whether we shift the curve slightly to the left or to the right typically does not have a large effect at this end. You know, even if this were to drop to 90%, it is still very high. So we don't get much effect at this end. Even though we do alter the affinity, we are still supersaturated in a sense that diffusion occurs. Remember, diffusion occurs within that first 0.25 seconds of transit time. We have plenty of time. So even if we slow or decrease the affinity, we have more time for the oxygen to bind, even though it may bind slower, may not bind as tight. For the most part, it does come to a complete saturation or nearly so. So that certainly isn't an issue. Now we're going to look at a carbon dioxide dissociation curve. Okay? This is much different. Now remember, carbon dioxide, as it's produced at the tissue level, is about 46 millimeters of mercury. So we start with a content of CO2 at this point, and when we reach the alveoli, it comes to a new equilibrium of about 40 millimeters of mercury. So we just drop from this point to this point, not very far, but as you can see, it's very linear. And even if we were to decrease this further through hyperventilation, decrease the CO2 content, it is still a linear relationship. It is not a curve like oxygen is. So CO2 comes off in a linear fashion, but we can still calculate CO2 production as opposed to oxygen consumption. So CO2 production, once again, is equal to the cardiac output times the difference, this time the concentration of CO2 in the venous circulation, because that's where it's produced and that's where it's highest, minus the content of CO2 in the arterial circulation, because that's where it's lowest. That's because we just release it into the alveoli and back to atmosphere. So to calculate this, you can see that CO2 production under normal conditions is about 200 ml per liter. 200 ml per minute, sorry. So now is what we want to do is we calculate oxygen consumption, CO2 production, and this ratio is called the respiratory exchange ratio. For a normal person, you do the calculation, it's 200 ml divided by 250 ml. This respiratory exchange ratio is typically 0.8. So that's a normal ratio calculation. So now you can calculate this, if you like, and see how you differ from normal. Are we producing more CO2 than we're consuming of oxygen? You know, does this ratio change? That can indicate various metabolic diseases as well. So this exchange ratio is important. So as we talk about that, once again, we talked about CO2 produced divided by oxygen consumed. Now, for the most part, this is very dependent on caloric intake and ranges between 0.7 if you eat a lot of fatty acids and 1 if you eat a lot of carbohydrates. Because remember, oxygen consumption and CO2 production is relative to what we call cellular respiration, and that's where we actually metabolize the foods that we eat. So depending on what our diet is, this ratio can change a little bit based on our diet. So as we look at that for a normal diet, we're at 0.8, and as we alter that diet, it can change a little bit from there. So either 0.7 up to 1. So it's got a small range of variability depending on your diet. But once again, this respiratory exchange ratio can be used to help calculate oxygen consumption, CO2 production, and the association between those two. Now here we look at the respiratory exchange ratio in its relationship to alveolar gas equation. So here we're going to talk about this respiratory exchange ratio, and to give us an ability to calculate the partial pressure of alveolar oxygen, or more so to look at the relationship of alveolar oxygen to this gas ratio. So alveolar oxygen, or partial pressure of oxygen, is obviously directly proportional to the inspired partial pressure of oxygen. So as this goes up, which makes sense. If we breathe a higher concentration of oxygen, our alveolar oxygen increases. And you can see the association of also the alveolar partial pressure of CO2 relative to this ratio. That can be broken down and give you the relationship. So as we increase or decrease this ratio, it has an effect on alveolar oxygenation. So it kind of helps put that in relationship and perspective when we're talking about respiratory exchange ratio relative to our alveolar oxygenation. Next, we're going to be talking about the control of respiration. And the control of respiration refers primarily to how do we regulate our tidal volumes and respiratory rate to accommodate our metabolic demands. How does our body do this automatically? But first, of course, we're going to go through a couple questions. So we will look at a couple questions here of material we've already covered before we get into respiratory control. So we have two questions for today, and I will give you 2 minutes to answer these questions. Once again, they are not that difficult. For the most part, you either know them or you don't, and I would hope that most of you would know them. So everybody get ready for their questions. We make that active. So first of all, which statement is not true about surfactant? So they're all true, but one of them. There's surfactant secreted by epithelial type 2 cells, increases surface tension of alveolar surface, is deficient in respiratory distress syndrome, RDS, consists primarily of phospholipids and proteins. Pick the one that is not true. Okay, you still have 30 seconds. All right, we still have 5 people who haven't answered. Let's get that in. Okay, so now we will look at our answers, unless anybody else wants to answer real quick here. All right. So, which statement is not true? Increased surface tension of the alveolar surface. Remember, surfactant decreases surface tension, not increase. And you can figure out, you definitely know it's secreted by type 2 epithelial cells. You know it's deficient in RDS. And it consists primarily of phospholipids and proteins. All right. You know, some of you have a short memory, but that's okay because we did talk about this a couple days ago. But make sure you review that and know what those are. One more question, because you're having so much fun at this. Okay, ventilated but not perfused alveoli is referred to as what? Anatomical dead space, anatomic shunt, extrapulmonary shunt, or alveolar dead space. Once again, you get the 2 minutes. Think about this. We've talked about this quite a bit. The different definitions between dead space, shunt, anatomic, extrapulmonary, alveolar. You got less than 30 seconds. Okay, everybody's got their answers in. Or not. You're getting close to it. Okay. Alveolar dead space. Now remember, we talked about ventilated. That means the alveoli are getting gas, but not perfused. Remember, perfusion refers to blood flow. So if it's not perfused, but it's being ventilated, that's dead space. And because it's inside the lung, that's alveolar dead space as opposed to anatomic dead space. Anatomic dead space refers to our conducting airway. Okay? So this would occur, as we say, not perfused, because we have a pulmonary emboli, or a blood clot in that vasculature, so there's no blood flow past it. So therefore, that's wasted ventilation, alveolar dead space. And let's see how well we did. Oh. All right, you guys need to review that just a little bit. All right? And certainly if you have any questions, let me know. All right, enough of the questions. We will now talk about control of respiration. Control of respiration is kind of a fun thing. Now, when we're referring to control of ventilation, most signals come from the upper brain centers, central nervous system. The central nervous system basically talks to the somatic motor neurons. Somatic motor neurons are those that affect your inspiratory muscles, such as your diaphragm, external intercostals, and your expiratory muscles. So that's their primary point. So they say inhale or exhale. And they also say inhale how much and exhale how much. Okay, so all of your regulation of ventilation comes through your somatic motor neurons for the most part. There is some that actually affects the smooth muscle cells that actually regulates blood flow and airflow due to constriction of those. So you also have some regulatory in that aspect as well. But this creates a rhythmic ventilation. This rhythmic ventilation is because we have all these inputs and these outputs through this central pattern generator. So this is found in the brain where all of these inputs come into, and also the excitation goes out to regulate the somatic motor neurons. The different regulators that say how much comes in and how much goes out is based on chemoreceptors. These chemoreceptors indicate what the status is of our metabolism, of our oxygen intake, CO2 production. So these receptors tell us what our physiologic status is, and they feed back. As well, there's other cardiovascular control centers that regulate this as well. As well, there's other modulators that we don't talk about much, but such as emotions, fear. Fear has a direct impact on your ventilatory pattern, as well as conscious and unconscious control. Primarily, most ventilation is under unconscious control. Okay? It's the autonomic nervous system that regulates this. However, as you know, we can consciously control our ventilation to a large extent. We can't indefinitely control it consciously because, as you know, try holding your breath. You get to a point where you consciously can't hold your breath any longer, and your autonomic nervous system overrides that and says, you have to breathe. Okay? So ultimately, the autonomic nervous system is in control. Okay? We can modulate that consciously to a degree within a particular range, but that's the best we can do. So let's talk specifically about the chemoreceptors. Chemoreceptors sense CO2, oxygen, hydrogen ion, all that's present in the extracellular fluid. Remember, the extracellular fluid can refer to the plasma in the blood as well as the cerebral spinal fluid. So we'll talk more specifically about the peripheral chemoreceptors. Peripheral chemoreceptors are found associated with the plasma in the carotid and aortic bodies. Okay, so the carotid and aortic bodies, there's actually a receptor or a chemoreceptor in the aortic arch, and there's also one in the bifurcation of the carotid artery from the internal carotid and the common carotid. So you have peripheral chemoreceptors in your arterial circulation. These are glomus cells in this receptor, and they're activated by decreases in PO2 or pH or increases in CO2. All of these can affect these receptors. However, these receptors are primarily responsive to changes in partial pressure of oxygen. So that's their primary modulator, even though CO2 and hydrogen ion will also affect the peripheral chemoreceptors. As well, we have central chemoreceptors. These respond primarily to changes in CO2. And this CO2 is sensed in the cerebrospinal fluid, and these receptors are found on the ventral surface of the medulla. And so they are most definitely responsive to changes in partial pressure of CO2. So how they fit into the scheme of things, primarily oxygen, pH, and CO2 all affect these peripheral chemoreceptors found in the carotid and aortic bodies. These affect the afferent sensory neurons, which feed into this central pattern generator. The central pattern generator accumulates and receives all inputs. All inputs from the peripheral chemoreceptors, the central chemoreceptors, as well as all other inputs such as emotions and voluntary control. This all feeds into the central pattern generator, and this will sort out what comes in and regulate what goes out. So within the central pattern generator, we have two primary areas of concern. We have the dorsal respiratory group, the DRG, which is responsible for activating inspiratory muscles through the phrenic nerve to the diaphragm and through the intercostal nerve to the external intercostals. So that is the primary pathway and regulatory area of the central pattern generator for inspiration. As well, for expiration, we have the ventral respiratory group. The ventral respiratory group activates primarily the internal intercostals and the abdominal muscles. So these are your expiratory muscles. So obviously during normal ventilation, we do not activate through the VRG under normal ventilation because these muscles are at rest. They're not active at all, so there's no constriction. So then in that case, the dorsal respiratory group is your primary source of your neurologic input regulating ventilation. So this will regulate our ventilation to a particular point. So if it increases respiration, it will increase it until we need to use the expiratory muscles to now increase the rate further. Because remember, we passively exhale. We can only increase our rate to a certain point before our expiratory muscles are now recruited to increase our respiratory rate so that we can force the exhalation to increase the rate. So under normal ventilation, at quiet ventilation, only the inspiratory muscles are used until it reaches that point where the expiratory muscles become involved. So you can see this pathway. These sensors in those glomus cells, in those chemoreceptors, are very critical for inputs. They are the two of the major inputs other than our emotions and voluntary control. So under normal respiration, this is your primary inputs. These are your primary outputs, and that's how the regulatory control occurs. Of course, you can look at this whole list and look at this layout because it's very important. Now, this is the peripheral chemoreceptor that's found in the aortic arch, as well as the carotid bodies here in the carotid artery. And the central chemoreceptor is found up here in the cerebral portion just above the medulla. So that's where the central chemoreceptor is located. And of course, your neurologic input to your inspiratory and expiratory muscles. You can see how that nerves come out. So these come out from either the DRG or the VRG in this central pattern generator, and they have separate innervations to the inspiratory and expiratory muscles. Make sure you understand the general flow and the major players associated with regulation. So as we look at this, as we mentioned before, when we're inspiring, an inspiration under normal resting conditions is what happens is the inspiratory muscles, the inspiratory nerves activate those muscles and they kind of recruit. So this looks at the number of active neurons, inspiratory neurons. You can see how they start activating as we start an inspiration, and by the time we reach peak inspiration, we have peak inspiration or contraction of our inspiratory muscles. So at this point, we hold our inspiration, so we have maximal nerve activity, activating those muscles to maintain that greatest negative pleural pressure for our tidal volume. And then when we exhale, everything relaxes. All the inputs stop, and it goes back to a basal level, and we passively exhale, and the volume goes out. So these nerves fire, but they increase and they summate their activity as we increase our inspiration. Now we talk a little bit more specifically about these chemoreceptors. The peripheral chemoreceptors found in the carotid and aortic bodies are comprised primarily of glomus cells. These glomus cells have the ability to detect changes in partial pressure of oxygen, as well CO2 and pH, but we're primarily going to focus on oxygen. So they can sense if low oxygen or partial pressure of oxygen, we get diffusion into these cells. Remember, everything comes to equilibrium. So low partial pressure activates these potassium channels, activates them to close. So if we close a potassium channel, that causes a cell depolarization. This depolarization causes a voltage-gated calcium channel to open. Now we get an influx of calcium, and as we know, calcium causes secretion or excitosis of dopamine-containing vesicles. So this neurotransmitter comes across this gap junction, activates this action potential on this nerve. This is a dopamine receptor, and hence our signal heads back to our central pattern generator, to the medulla. Okay, so that's one of the pathways feeding into that central pattern generator, comes from these aortic bodies or in carotid bodies, primarily from these glomus cells. All right, so it's very important to see how this mechanism and pathway occurs. Now, an important point here. Oxygen is not very responsive for everyday arterial oxygen regulation. Oxygen must drop below 60 millimeters of mercury to elicit a response. So we will not get a response here in the glomus cell unless this PO2 drops below 60 millimeters of mercury. As you know, remember, these are in the arterial circulation. What is the usual partial pressure of oxygen in the arterial circulation? 100. So obviously, under normal conditions, these are not activated. It would take a pretty hefty insult to drop the arterial oxygen below 60 millimeters of mercury. All right, so when that occurs, then these become active and they regulate through this action potential to occur. Now, an example of this is, say, a child holding their breath holding. Typically, a lot of people go into a grocery store with their young children. The child wants something. The mother says no. The child says, okay, I'll hold my breath until you give it to me. You know the scenario. I'm sure you've all done it, right? It's really not too much of a concern because they can only hold their breath until their partial pressure of oxygen in the arterial circulation drops below 60. Because as soon as that occurs, the autonomic system takes over and forces them to breathe. So you can rest assured your child is not going to die from holding their breath. Worst case scenario, their oxygen drops too low, they pass out, and at least they're quiet. So, not to worry, because once they pass out, once again the autonomic system takes over and they start to breathe. So it's all safe. Now we're going to talk about the central chemoreceptors. These are found on the ventral surface of the medulla. So what we have is the cerebral capillaries. Once again, this is arterial blood that just happens to be in the cerebral capillaries. These are associated with the blood-brain barrier. I'm sure many of you have heard of the blood-brain barrier, and that this barrier is quite impermeable to many things. However, CO2 has a high diffusibility. We've talked about the diffusibility of CO2. It's very high. Therefore, CO2 can diffuse across the blood-brain barrier into the cerebral spinal fluid. And lo and behold, look at this equation. That looks familiar. CO2 binds and combines with water in the presence of carbonic anhydrase, forming carbonic acid, dissociating to a hydrogen ion and a bicarbonate ion. The same equation that occurs in the red blood cell for transport of CO2. This just is a different location. This is in the cerebral spinal fluid. And now is what happens in this case. This hydrogen ion is what's responsible for binding to the central chemoreceptor and activating it. So in this case, the hydrogen ion binds and activates the central chemoreceptor due to the influx or diffusion of CO2 into the cerebral spinal fluid. An important point to remember here is that even if we have an increase in hydrogen ions in the blood, hydrogen ions are not permeable to this membrane. They will not cross the blood-brain barrier. Therefore, hydrogen ions are not directly capable of activating this from the bloodstream. It needs to come across as CO2, and then the hydrogen ion here is able to activate. So make sure you understand that difference. And once again, make sure you know this equation. So now as we talk about the central chemoreceptors, there's a variety of different things. Now, these chemoreceptors are very sensitive, and they do regulate our daily or breath-to-breath regulation. So if you were to increase the tidal volume voluntarily and your rate for a short period of time, then immediately this would respond and regulate that and change it and accommodate the CO2 and the oxygen. So these are very sensitive and very quick. Obviously, as every time the blood passes by through your brain, this tells your brain exactly what your ventilation is relative to the demand or the need of your body. So this receptor does respond immediately. However, under certain disease conditions or certain environmental conditions, if you are exposed to high partial pressures of CO2 over a period of time, a long period of time, as in several months or at least several weeks, but typically several months, if you have a high partial pressure of CO2, now this can occur either adaptive due to altitude issues, or primarily is what we're going to refer to is in patients with emphysema. Patients with emphysema have a tendency to have high CO2s. Remember, in emphysema, they have a difficult time exhaling. If you have a difficult time exhaling, what does that primarily affect? Your CO2, because you can't get rid of the CO2. So what they do is they breathe on a higher volume, higher FRC, higher residual volume, but all that does is give a bigger pool for the CO2 to accumulate. So the CO2 has a tendency to be high in emphysema patients, especially as emphysema advances in some of these patients and gets very severe. So in this case, they lose their response to carbon dioxide. Now here, for some reason, I've got to low carbon dioxide, but it means to high carbon dioxide. So in this case, if you lose the sensitivity to high CO2, typically also an indication with emphysema patients is that they breathe oxygen on a regular basis. Okay, so now if they're losing their sensitivity to CO2, they're breathing oxygen to help supplement their oxygenation, because also with emphysema, you know that they can have a low PO2, low arterial oxygen, so they breathe supplemental oxygen. If you're breathing supplemental oxygen, your partial pressure of oxygen in the arterial circulation is going to be high, elevated, okay, or normal. So the peripheral chemoreceptors will not activate when they're breathing oxygen. Their central chemoreceptors don't activate because now they're desensitized and they don't respond to CO2. So what happens? They stop breathing, okay? It's very common for patients with emphysema to have episodes of non-breathing, apnea, okay? So they stop breathing for periods of time because the chemoreceptors are not activating. Remember, the peripheral chemoreceptors, oxygen's got to drop real low, but if they're taking supplemental oxygen, that doesn't activate, and their CO2 builds and builds, but because this is so desensitized, that doesn't activate. So they go for periods without breathing, and then all of a sudden they'll start to breathe, and then they'll hyperventilate to bring the CO2 back under control, and then they'll go into apnea again. So it's very common for patients, advanced emphysema patients, to go through these episodes of not breathing and then hyperventilating back and forth. Now the biggest problem is, while these patients sleep, they typically don't take supplemental oxygen. In that case, if they're not responding to CO2, at least, you know, if they're not taking supplemental oxygen, their oxygen will drop below 60, but they go through these very hypoxic episodes in that case. So now they're getting hit with these very hypoxic episodes in addition to apnea and then hyperventilation. So emphysema is a very terrible disease, and all it does is progress and get worse. There is no cure for emphysema. There are several treatments to help slow the progress, but it does not cure it or reverse the progress. Another example we can talk about with regulatory control here with peripheral and central chemoreceptors are athletes who compete in races, primarily swimmers. Now, if you're a sprinter and you're swimming, the idea is to not take as many breaths because it slows you down. Every time you turn your head to breathe, it slows you down. So sprinters in the swimming pool try to hold their breath as long as they can. What helps them to hold their breath longer is they hyperventilate prior to the race. If you hyperventilate, what does that do to CO2? Drives it way low, okay? The more you hyperventilate, the lower you push the alveolar and the arterial partial pressure of CO2. So if we drive that CO2 real low, it's going to take a while before it accumulates high enough to activate inspiration through the central chemoreceptor. As well, through hyperventilation, what's it do to the partial pressure of oxygen? It increases. Therefore, we get a little more oxygen into our bodies, even though we know under normal conditions we're 100% saturated. So hyperventilation doesn't help you much with the oxygen end of it, but it does help a little bit. It'll drive the partial pressure up just a little bit. So hyperventilation helps these swimmers to keep from breathing until their oxygen level drops below 60 or their CO2 climbs high enough. But if they blow their CO2 down low enough through hyperventilation, it's basically when the oxygen reaches 60 millimeters of mercury that they will have to take a breath. So they can actually go quite a distance without breathing if they hyperventilate and decrease their CO2. Now the downside of this, there's a lot of recreational divers who, like pearl divers and people like that, who are snorkeling, and they dive to great depths and they hold their breath. They do the same thing. They hyperventilate so they can hold their breath longer, go deeper, get the better pearls, the better oysters. And what happens sometimes in those cases is that because they blow their CO2 so low, they can hold their breath a long time, they get to the bottom. However, their PO2 eventually hits below 60, and at that time, or lower, and a lot of these people get so accustomed to driving their CO2 so low, their oxygen actually gets lower and lower before it kicks in. So instead of kicking in their oxygen receptors at 60, they even push that a little lower. Unfortunately, what happens is if your oxygen drops too low, you pass out. Okay? And if you pass out at the bottom of the water, you're in trouble because now your autonomic nervous system takes over and you start to breathe. So obviously, that's very dangerous if you do that to a great extent. So hopefully everybody understands the peripheral and central chemoreceptors, that oxygen is the primary sensor for peripheral, but it's not your day-to-day regulation. However, the CO2 is. This here is just nothing more than a summation of what we've talked about. We talked about the receptors, the afferent neurons going to the brain, the central pattern generator, and the medulla and the pons. And this is the effectors, the skeletal muscles, your inspiratory and expiratory muscles, as well as the smooth muscle of your bronchioles and your capillaries, or your small arterioles. So it will also regulate blood flow and airflow to these organs as well. And of course, your response, you alter your minute ventilation, and hence you go back around again. So once you alter your ventilation, you affect these receptors again, and you get an immediate feedback mechanism. So it's a nice little cycle in which you get this regulatory control. So we've talked about the different chemoreceptors associated, but there's also some mechanoreceptors associated with regulation as well. There's a pulmonary stretch receptor located in the lungs. So when your lungs reach a particular distension, this receptor activates and says stop inhaling. So it's very important so you don't overexpand your lungs. What can happen if you overexpand your lungs? You can actually burst a hole through the alveoli, and if you do that, that can go into the pleural space. And now if we've neutralized the negative pressure in the pleural space, what's that called? Pneumothorax, okay? So this prevents you from creating a pneumothorax by overexpanding your lungs. It's like a balloon. You blow it up too big, it pops. Same thing with your lungs. They'll do the same. As well, there's mechanoreceptors or muscle spindle fibers in the diaphragm, the chest wall, abdominal muscles. All of these have limitations due to mechanoreceptors. So they will only go to certain ranges before a receptor kicks in and says, that's it, stop. That's so you don't create damage to yourself. So if your mother's not watching, your body is. And there's also a variety of other neural inputs that we talked about, cardiovascular centers, cerebral cortex, hypothalamus. All of these things feed in, and these are just kind of minor contributions, such as emotions and other environments that can also have some minor effects. But we're talking about the major effects through these chemoreceptors. Those are your major regulatory aspects associated with that. And of course, we talked about our skeletal muscles, such as inspiratory and expiratory muscles, smooth muscles of the airways and the vasculature. So make sure you know that the response are changes in minute ventilation. Okay, and these translate, of course, into alveolar ventilation depending on the change in pattern. So if we alter tidal volume relative to rate, or alter rate relative to tidal volume, or we change both of them. So this is all very important. All of these feed in. Once again, this is nothing more than what we've just talked about, the whole cycle of pattern. It just lays it out in a different way so that you can look at this and understand, the route of regulatory control through the central and peripheral chemoreceptors. Once again, this just goes and shows what we talked about, our CO2 regulation and the cerebrospinal fluid. And it's the hydrogen ion that activates these receptors. It's not the CO2 directly. CO2 will cause these changes, but it's the hydrogen ion that actually binds the receptor. This here starts to show a little more extent to regulation. As we can see, we said CO2 is our best regulator of ventilation. So on the left axis here, the y-axis, you can see alveolar ventilation relative to changes in PCO2. And you can see that the curve is quite steep here. That means it's very sensitive to changes in CO2. The steeper the curve, the more sensitive it is. Here, pH, this curve is much flatter in the physiologic range in which we're referring to. So that pH is not very sensitive to controlling alveolar ventilation. And this just shows the effective control over time. This is like a breath-to-breath regulation based on CO2. So CO2 controls this very tightly. As well, we talk about other regulations in oxygen. Remember, oxygen, atmospheric oxygen starts at 150. But as we look at the partial pressure of oxygen in the arterial circulation, we have absolutely no response in ventilation until it reaches 60. And then we have a very sharp response. So it's very sensitive when we get that low, but typically we don't get that low under normal conditions. So here this once again indicates the sensitivity, but when it actually activates in the range it activates. Unlike CO2, that's fairly active over a very long range. So this actually is our safety zone. In other words, once we get to the 60, now we're safe, and that will actually help regulate our oxygen content, at least on the lower end. We only have a couple slides left here. We can probably make that. We're good. Once again, we are going to talk about the sensitivity of these reactions. In this case, we're looking at changes in PO2. We know that PO2 is not active until we reach 60 millimeters of mercury. But look at these three lines relative to the partial pressure of CO2. Now, this one in the center is our normal partial pressure of CO2. If we increase the partial pressure of CO2, now we become more sensitive to oxygen changes below 60. So you can see how increasing CO2 increases the sensitivity of oxygen as the oxygen decreases. Very important to see that. Now, if we have a very low CO2, that decreases the sensitivity to oxygen. So in this case, when we talked about hyperventilation, we blow our CO2 real low. See how we become less sensitive to oxygen? Once again, that makes it very dangerous for these divers who go down, hyperventilate. They have a very low CO2 relative to oxygen. So now they lose that sensitivity to oxygen as they make that CO2 lower. Likewise, here when we look at changes in CO2, remember CO2 of 40 is our normal zone here. If our oxygen is 100, so as we increase our oxygen, now we increase the sensitivity of the CO2. See the steepness of the curve. So, it's less sensitive because it's flatter. We become more sensitive as we decrease oxygen. Now, all of this makes sense because if our oxygen's lower, we want to increase ventilation. If our CO2 is higher, we want to increase ventilation. So they work together. Basically, what it says is hypoxia plus hypercapnia, which is high CO2, equals a summation of effect. Okay, so they basically summate. So the lower the oxygen, the more likely you are to breathe. The higher the CO2, the more likely you are to breathe. You combine them, that enhances the effect. Okay? So that's what these graphs demonstrate, that they enhance the effect of each other. And once again, when we look at pH, we get the same thing. Here you see a normal pH, and as we become alkalotic, we're less sensitive. Acidosis, more sensitive. Acidosis refers to hydrogen ion. So we know that hydrogen ion indicates we need to increase our respiratory efforts. Okay, so once again, all of these are very effectual and have changes in regulation on our regulation of breathing. That'll do. Thank you.